Okay, good afternoon. Hello, everyone. Welcome to the first Inequality seminar of our new year here at the International Inequalities Institute at the LSE. My name is Francisco Ferreira, and I'm delighted to be chairing today's seminar, which is on unfair health inequalities in the UK by Dr. Paolo Brunori. Paolo, as many of you will know, is an assistant professorial fellow with us at the International Inequalities Institute at LSE. His research focuses on inequalities and more specifically on inequality of opportunity. And Paolo has been, over the last decade or so, one of the leading scholars working on the measurement of inequality of opportunity. So we're delighted to have him today. Our seminar, for those of you who are used to it, is a Zoom meeting format, which is a little more interactive. So, please do keep yourself muted, but if you can keep your screen on, that's wonderful. Many of us are speakers as well, and you know that it's a lot nicer when you can see the people you're speaking to rather than just the black boxes. So to those who can keep their screens on, that would be wonderful. There'll be opportunity for questions and answers at the end, and at that time, if you could raise your virtual hand on the functions, the reaction functions there, so I can see you. I'll give you a chance to ask Paolo a question. Just before we start, a quick mention of the next seminar that we'll have, which is next Tuesday, the 25th, at the same time, 12:30 London time. Is going to be on the impact of COVID-19 on global inequality and poverty. So quite a hot topic, and that'll be by Nishant Yorant and Christoph Lachner and company. There'll be a link to that event as well in the chat. So with that, welcome again, and without further ado, over to Paolo. Thanks, Paolo.
Thanks, thanks, Chico. Thanks for this nice introduction, and also now I'm at home, but it's really a pleasure to have the opportunity to present the III seminars, because I think it's a way to connect with people doing research on similar topics around the world, which is really super. The paper I'm presenting today is a joint paper with Apostolo Stavillas, Andrew Jones, and Giovanna Scarchilli, and is a paper about the measurement of unfair inequalities in health. The paper basically makes two contributions. The first one is methodological, because it presents the possibility to use a very interesting and advanced machine learning tool, which is called model-based recursive partitioning, was developed by Zales and co-authors a few years ago. And then we also have an empirical contribution, because we fully exploit the longitudinal household surveys for the UK, which contains a lot of interesting information about health, behaviours, and socioeconomic backgrounds of a representative sample of British households. So let me start, because I'm not an expert at all in health. Let me start trying to explain at what kind of health inequality we are thinking at. There are many possible definitions of health inequality, but I find this one by the World Health Organization extremely convincing and clear. And I find four interesting parts in this definition. The first one is that when we think at inequality in health, we generally think at inequality between groups. The second is that these groups are defined by social and environmental conditions in which people are born, grow, or live. And then this inequality are considered unfair. And finally, something we will not discuss here, but which I think is interesting, they can be, if not eliminated, at least reduced. So these four elements, I think, really have a lot to do with what I'm gonna tell you. And of course, it exists a robust literature made of people that do research in health as the main interest of the research. So there is a long tradition of measurement of this type of health inequality. But here our starting point is to some extent lateral to the mainstream literature. And it is rooted in a debate between moral philosophers and economists interested in fair allocation and fairness in general about the debate has been called equality of what? So a debate about what type of egalitarianism a society should try to achieve. And this approach we refer to, which is called responsibility egalitarianism, because it claims that there is some space for inequality in a fair society. And this inequality is inequality due to responsible choices, have been formalized in a number of ways by different authors. And there is a paper in Journal of Health Economics in 2009 by Ferreira that proposed how this approach could be implemented when measuring inequality in health. Interestingly, this approach by Ferreira, I don't think, I am not aware it was ever implemented to data, although it's very elegant and interesting from a theoretical point of view. A parallel literature instead, which is more in general called literature on inequality of opportunity in health, is growing, and there are many contributions that do measure health inequality as health inequality of opportunity. And it is a parallel literature because also in this case, what we do is to measure inequality, allowing some part of it to be legitimate and not unfair, because we consider it due to choices. So this literature is not only an interesting academic debate, but is also part of, it also contributes to an interesting debate that is part of the public debate. So there are discussions about whether individuals that make unhealthy choices in their life should be treated differently from individuals that do behave healthy in their life. This is taken from The Guardian. It's rather old now, but it's the well-known debate about the George Best liver transplant. But also today in newspaper, you often see a discussion. This is an Italian newspaper, for example, about whether the costs of intensive care treatment of individuals that refuse to get vaccinated against COVID should be paid by the state or not. So this idea of having choices into the measurement of health inequality is not only an academic debate, but it's also deeply in the public debate and in the newspaper and in the common understanding of fairness in terms of health by people. The model proposed by Ferreira and Choquette can be is rather simple, and it can be shown with this simple equation, in which age, which is the level of health individuals obtain, is the result of a number of variables that are circumstances beyond individual control, basically the list of unfair sources of inequality that were listed in the previous definition of health inequality, a number of choices, responsible choices that we call them effort. And then there are demographic characteristics, so basically the age, and a random component, which is in practice a mix of what is random and what we simply cannot measure. For explaining what type of measurement, okay, Guido, do you want to ask a question? You can.
Very short for clarification. Why is it important that demographic characteristics and circumstances are separate? So is this relevant?
Yeah, it's relevant because, as I will shortly say, we will look at age-adjusted measure of health. So we accept that we all gonna get old and our health will deteriorate and we will eventually die. So this is not considered part of the inequality we want to model in this case. So that's the reason why we keep it separated in this equation. We define as types individuals that share the same circumstances, and we define as effort tranches the groups of individuals that make same choices. So this terminology is taken from the model by Romer, but it can also be used in this theoretical approach. Here I have an example of what I've just told you. So we are going to ignore demographic characteristics. So we look at the health-adjusted measure, age-adjusted measure of health. We are going to also ignore the random component as far as this random component is orthogonal to both circumstances and behaviors. And here we have an example that we will use in this to present the model, in which you have two circumstances, race and gender, and one behavior, which is basically how many cigarettes you smoke per week, per day, sorry. So basically you have four types, which are the rows of this matrix. And then you have six columns, which are the effort tranche. Okay, because in this simplified world, we have only one variable of choice for which the society wants to hold the individuals responsible, and only two circumstances. Okay. In order to get a measure of unfair inequality, Ferreira and Choquette propose to do the following. They basically propose to take this distribution of health that you see here and to modify it into a counterfactual distribution that we will call the H tilde, which is obtained from the distribution H and has two properties. The first one is that H tilde does not contain any legitimate variation in age. This is because we want our measure of unfair health inequality to be consistent with the reward principle, and the reward principle basically says that the good and the bad you get from your choices should not be considered part of the unfair inequality. So basically, variations within the column, the rows of this matrix should not be part of the inequality we consider unfair. Then there is a second property H tilde should have, which is that H tilde, I see that I'm repeating what is in the previous bullet, I'm sorry. So H tilde does contain all illegitimate difference in age, which is due to the compensation principle, and basically is saying that any inequality within column of this matrix should be part of H tilde. So when I measure inequality, I should be sensitive to any difference I read within this column, so within tranche. The problem is, and this is clearly explained by Marc Ferreira, the problem is that unless the data generating process is additive and separable, the two principles are incompatible. And I give you a easy explanation of this. So here I focus only on two of the four types we have in the example above. And here you see the worst of type, black female, that get a lower health on the vertical axis, no matter their behaviors. And then you have the best of, which is white male. Okay, so when I want, so I see the distribution, and I have to, from this distribution, to create a counterfactual distribution consistent with both the principles I've just shown you. So let's first of all consider the worst of type, black female. In the counterfactual distribution, individual in this that belongs to this type, they should all have the same value. Why? Because what the difference in the health they get is due to the choice they make. So any inequality that I observe within this group of people should be also represented into the counterfactual distribution. And the same, I should say, for the other type. Okay, so any inequality within these individuals in the black female type should not be part of the counterfactual distribution. So any individuals that belongs to this type should be represented by the same value. And the same thing for white male. Okay, now let's forget for a moment about types, and let's look at individuals that belong the same. So for example, people that never smoked here. Okay, so what I should observe here in a fair society is that they get the same outcome, but I see a difference. All this difference between white male and black female that behave the same, so they never smoked, should be part of the counterfactual distribution. So should be represented into the counterfactual distribution, because these are all unfair inequality. And the same for any possible level of smoking habits, okay? But the problem is that here I'm saying that all black females should have the same value and all white males should have the same values, but that the difference between them that clearly varies depending on the behavior should be fully reflected into the counterfactual distribution. And this is impossible, okay? It would be possible only if these two lines were parallel one to each other, which would mean that the data generating process is additive separable into the two factors, so circumstances and effort. Okay, so to solve this incompatibility, Ferreira and Schocker propose two possible measures. So they say, okay, we cannot have a measure of unfair inequality that is fully consistent both with the principle of compensation and the principle of reward. But what we can do is that we can focus on one of the two principles and then try to minimize the violation of the others. So the idea, for example, of the measure direct unfairness is to keep consistent with the principle of reward, which requires that all individuals belonging to the same type get the same values into the counterfactual distribution, but also keeping consistency with the principle of compensation for a reference level of effort. So for example, you have in mind that there is a correct behavior, which is never smoke. So you want your counterfactual distribution to fully account for the fact that people that never smoked have different level of health due to their circumstances. And this is unfair. So you fix the reference effort, never smoke, and you assign to all individuals the level of outcome, of health outcome they would get if, belonging to the type they belong to, they would behave as the reference. So they would never smoke. In this way, you obtain a counterfactual distribution which is fully consistent with the principle of reward and is also consistent with the principle of compensation for people behaving as the reference, but you will have violations for all the other individuals. Another option is to favor the principle of compensation, saying, no, I want my counterfactual distribution of unfair inequalities to contain all violation of the compensation principle. Whenever I see two individuals behaving identically, but belonging to different types, their difference in health should be part of my counterfactual distribution. This will imply a violation of the principle of reward. So you will basically treat differently individuals that are in the same, that face same opportunities. They are characterized by same circumstances. And you can do this by replacing individual outcome with the difference between their outcome, their health, and the expected health they would get if they were behaving as they are behaving, but they would belong to a reference type. Okay. So in this way, you preserve consistency with the reward principle for a reference type. You don't for all the other types. It is less intuitive how you can choose a reference type. It's more intuitive how you can choose a reference behavior, but you may find a good criterion to choose the reference type, which could be, for example, the worst of. And you will have a measure fully consistent with compensation and in part consistent with the reward principle. It is important to underline here that at the end of this, we are left not with one measure consistent with the reward and one with compensation, but with families of measures, because there are many possible reference effort and many possible reference types. Okay. What you have to do then are two things. One, you have to define types, and the other, you have to define effort and model how effort and types interact together. In previous contributions, in health, the choice of how to partition into types the population was basically arbitrary. In recent contribution, unsupervised machine learning algorithms such as latent class model were proposed. But the problem with this model is that they are very expensive in terms of parameters, and they end up partitioning the population into a very low number of types, like 4 or 5 types for the British population. In this paper, connecting to other papers that use tree-based model into the literature of inequality of opportunity, we propose to use model-based recursive partitioning algorithm. And now I'm going to try to explain briefly how this algorithm works. I skip the explanation about what is a tree, and I will go straight forward to explain you what is a model-based tree. So the model-based tree is a prediction model that is used in forecasting that predict a dependent variable, in our case health, as a function of a number of circumstances and a model. So in our case, we have a model in mind, which is the model that explains my health as a function of my behaviors. And then we suppose that this model may be heterogeneous in terms of parameter, depending on the realization of certain circumstances. So that I have a different advantage or disadvantage from being from more or less favorable circumstances, and also that the return to my behaviors may depend on my circumstances. So the model starts by setting a confidence level, 1 minus alpha, and then fit a model in the entire sample. In this case, our model is extremely simple. Is my health is a function of an intercept plus a slope that multiplies my behavior plus an error term. Then I proceed, the algorithm proceeds by running an M fluctuation test to test the instability of these two parameters, beta 0 and beta 1. What is an M fluctuation test? For me, the best way to understand what it is to think at test for the identification of structural changes in time series. When you search for a structural change in time series, what you do is basically starting from a model that you assume to be valid for the entire time series, and then you search whether there are sub-periods of the entire period you observe that, once you isolate them, create an instability in the parameters. And this is done running a test, calculating a statistics on the cumulated sum of residuals of your population model. If you are able to reject the stability hypothesis, so you do observe that there is an instability of the parameters once you partition into subgroups your observation, then you do split the sample. If you don't, you stop. Once you have obtained two subsamples, you repeat the step from 2 to 5 on the resulting subsample. What you get is something like this. So in this case, we have a simplified example in which you obtain two different models fitted into two subgroups. And the two subgroups, that are the terminal nodes of these three, are obtained by partitioning the population based on a circumstance which is parental education. Here you find the p-value of the test, and then you find the two resulting subsamples. Once we have these models, we basically have the model that we need in order to calculate the unfair inequality, and we can proceed. So now I'm gonna apply this method using the UK Household Longitudinal Survey. So we define health outcome as the physical component of the short form 12 score, which is a standard score to evaluate the health status of individual. And we observe this in wave 6. We also observe a number of circumstances behind the individual control, which are gender, ethnicity, parental education, and parental occupation, recorded at age 14. And then we have a number of lifestyle variables, which are dietary behavior, how many vegetables and fruits you eat during the week, your smoking behavior today and in the past, your sport activities, whether you have a sedentary life or not. And these behaviors are recorded in previous waves, so in 2010 and 12 and 2013 and 15. This in order to avoid some form of reversal causality in the exercise. We summarize these behaviors into a variable of effort. So this is done both to simplify the empirical estimation and to make the model parsimonious enough, and also because we consider lifestyle as an intrinsically non-observable behaviors that can be summarized to some extent looking at a number of observable behaviors like the one that we observe. So we want to extract a variable of lifestyle from the covariance of these variables, and we do this by principal component. So here I'm showing you the output of the principal component, in which you see that the first component of this principal component analysis summarize the 43% of the total variation. So it's a very convincing summary of the behaviors. And also you see that there is a consistency, the consistency you expect with the sign of this correlation. So you see bad behaviors moving in the same direction and good behaviors moving in the same direction. So we have a measure of effort. We have a measure. We have a number of circumstances. We have a model in mind, which is an OLS explaining my behavior as the result of this summary of my, explaining my health as the result of a summary of my behaviors. And we can estimate the model. And this is what we get. So this is, I hope you can see something, but this is the MOB for health, age-adjusted health in the UK. So what you notice here is, first of all, a rather poor fitting of the OLS in the terminal nodes. So you see that these OLS regressions, they all have the expected sign, which is the more healthy is your behavior, the higher is your expected health, but the correlation is low. And this is what we have to say. So what the first important conclusion of these studies is that using this data set, which is very sophisticated, and using this clever algorithm, we are still able to explain 8% of total variation in the SF score that we observe, which is not much. Okay. But on the other hand, looking at these three, you can notice many interesting things. The first one is that the first and most important factor of instability of the parameter is ethnic group. And to the left, you have white respondents and black. And to the right, you have Asian, mixed, and other minorities. Then if you follow the path of these splits, you will see the different types. I'm going to show you only the best and the worst of in terms of expected outcome. This is the best of type and is made of male, white or black, with both mother and father well-educated. Okay. And they have an expected outcome which is far above the average in the population. This instead is the worst of type, which is made of female with Asian or mixed or ethnic origin, and with a non-working mother. And they have an expected health, which is impressively around the 25th centile of the population, of the distribution into the population. So it's far below what you expect in the population. We can summarize the result of this model with a simple matrix that contains basically the population share, the expected health, the average effort exerted, and then the parameters beta 0 and beta 1 that are all statistically significant. And what you observe is a clear monotonic relationship between the expected health and the intercept, beta 0, so which implies that there is a clear and fixed social gradient in terms of the fixed effect of belonging to a given type, while a much less clear, if any, relationship between the return to effort, so the slope of this regression lines, and the expected outcome. Okay. Here we represent all the regression lines we have in the model, and basically this is interestingly the opportunity set of each individual. So each individuals belonging to a given type have an expected health, which depends on their type and how they decide to behave. And what you see clearly here is that if you belong to the better type, the better of type, no matter how you behave, you will get a higher expected health than than someone belonging to the worst of type and at the top of the behaviors in terms of health. Okay, so there is a clear dominance between these two types. Okay, we are not done. We cannot use this modeled distribution to calculate the families of measures, direct unfairness and fairness gap. We have to think a little bit more about the meaning of exerting effort when you belong to different types. Because as suggested by Romer, when you belong to a different type, so you come from a poor socioeconomic background, for example, you don't simply have less opportunities, but you also may be not in the condition, you have less incentives to exert effort. So you will tend to behave in a different way. You will have, it will be harder for you to properly behave. So as suggested by John Romers, in order to take into account the fact that belonging to different types give different incentives and impose different constraints in the ability of individuals to exerting effort, we remove the indirect effect on health through different systematic differences in efforts and in behaviors, using as the morally relevant level of effort, not the level of effort itself, but the quantile of the type-specific distribution of efforts, which means basically that these are the density function of the effort distribution across types. What we do is we construct a counterfactual distribution, looking not at the level of effort per se, not at the principal component of the behaviors, but at the quantile. So we compare effort distribution quantile by quantile. Here, what you notice is that there is a tendency of better of type are ranked by their expected outcome. So individuals in better of types tend to exert more effort. You see this clearly, but probably the most important characteristics of this type specific distribution is that better of type tend to have a more dispersed distribution of efforts. Okay, so after we take into account for the indirect effect on health of circumstance through a different distribution of effort, we obtain the counterfactual distribution. So our opportunity set becomes broken lines because we are comparing individual exerting different absolute level of effort. But then we can use this modeled distribution to measure unfair health inequality. And what you can observe here is that still there is this clear social gradients with the better of type getting more expected health, no matter how they behave, comparison with the worse of type. And also you see somehow a divergence. So the heterogeneity in the distribution of effort, the fact that better of type have a more dispersed distribution of effort, make at the very beginning worse of type to catch a little bit up. So they tend to get closer the expected health of people in a worse off situation when they start exerting some effort, but then they tend to diverge for top performing individuals. This is what we use to estimate the inequality or unfair health inequality. Here I show you the unfair inequality in health as measured by fairness gap as a share of total variance. And what you see here is quite confusing in the sense that you see that if you use a compensation consistent measure of health inequality, you will have a very different share of total inequality explained as unfair, which ranges between 30% and 50% basically, depending on the reference type you choose. And this makes sense because by definition, if you use a reference type that has a slope of 1, you will have 50% of the inequality into the counterfactual distribution. While if you use a reference type that has slope 0, so for your reference type, there is no effect of effort on outcome, then 100% of your inequality will be unfair. So this rather erratic trend into the level of unfair inequality when you change the reference type is simply the direct consequence of an heterogeneity into the slope of the return to effort, where there are types with a good return to effort, then inequality of opportunity in health become small, while when the return to effort is very low, inequality of opportunity becomes very large. A different picture appears when you look at reward consistent measure of unfair inequality. And here you have a clear U-shaped trend, which is exactly due to the first convergence and then divergence of words of type I was discussing before. So if you look at the extreme of the effort distribution, lower and highest quantile of effort, you will tend to see types far away one from each other. But this is mainly driven by the fact that people in the top and in the bottom of the distribution of effort in different types exert different absolute level of effort. Also, what you see here is that you identify as unfair between the 18% and the 33% of total variance in health. So let me conclude by saying that we started this project thinking that MOB was an absolutely promising method to estimate unfair inequality in all cases in which you can observe behaviors, because you are able to model unfair inequalities as the result of direct effect of circumstance on what you get, and also a different return on how you behave. So for us, this is extremely promising as an approach. On the other hand, when you try to take these two data, you note that it's extremely demanding. Even if you have one of the best longitudinal surveys to perform this type of exercise, the variance we are able to model is only 8%. But interestingly, up to 50% of this 8% is unfair. Another important thing is that apparently harmless normative choices, like do you want to be fully consistent with the reward principle? Do you want to be fully consistent with the compensation principle? Or even inside the family of reward and compensation consistent family type or the reference effort you want to use, this apparently innocuous choices in fact have an enormous impact on the message you will end up giving to policymakers and your contribution to the debate. So one of the conclusions of this study is that maybe in this literature we should probably favor a little less the theoretical soundness of what we measure and try to find pragmatic and simple solution to the complex and interesting theoretical problem that were identifies, such as all the discussion about reward and compensation consistent measures. I'm done.
Great. Thank you, Paolo. Time for questions now. But Paolo, if I may, let me just ask two quick questions. One, just very factual and empirical. It's whenever I see analysis of this kind for the UK, I'm always amazed by what happens to Blacks as opposed to Asians. And it was again the case in your study here that they are grouped with the whites, right? They're grouped with the better of types, and not only that, but even at a corner of the tree that you had a further subdivision by ethnicity. I think then the blacks, the division was still blacks and other kind of whites, Irish background and so on and so forth, as opposed to a clear black and white thing as you would see, say, in Brazil or the United States. So this is really interesting, and I remember another paper on educational inequalities in which there was a similar outcome for the UK. So I wonder if you have any light to shed on that, or whether other people in this call who know the UK much better than I, can speak to that. That's one just empirical issue. The second one is more conceptual, and it has to do exactly with what you mentioned at the very end, which is that perhaps inequality of opportunity is ripe for a sort of Piketty type shock, in which we go from lots of different measures to, okay, here is the share of the 1%, and it shocks people, and they think, okay, this is how much inequality there is, and so on. Now, if you were, I understand the various distinctions, theoretical distinctions that you described in terms of fairness gap and so on. But if you had to pick one, if you had to pick a measure to speak to policymakers, say a share of those 8%, which one would you pick? Would you pick a reference type, say the majority or the worst off, or a reference effort level, and have that share? Would you think that there is any merit in being brave and picking one of those and saying, okay, this much, this share of explained inequality in health in the UK is unfair, as opposed to providing the full range, or at least as a sort of focal point for the full range, or not? So let me leave it there, maybe get Stephen's question in, then go back to you, and then we'll get the two polls after that. So Stephen, over to you, please.
Hi, thanks for the talk. I was just sort of basically trying to figure things out. One of the steps along the way, Paolo, is dividing a measure of health from a series of multiple indicators, and you use first principle component, if I understand you correctly. I'm just wondering to what extent your approach is vulnerable to problems because you do that, whether or not there are other ways of summarizing or extracting whatever is meant by health in that particular way, whether or not, therefore, your mob regressions are affected by this. And this is related to your comments about proportion explained. And then finally, I just wonder what would happen if you just used one of the health variables rather than your composite. So a series of related questions about how it all goes together. Thank you.
Thanks, Stephen. Do you want to take those first, Paolo, and then we'll do a second round?
Yes, thanks. So the first one, I think I need to share again my screen, because you are right. So I was, with my ignorance about the UK and about health in general, I was shocked by. So I was expecting Black to be together here with the other minorities, but then here this last. I think you were referring to this type 6, which instead is consistent to what I was expecting. No? So like Irish white, other white, Black together, and UK whites slightly better. So, but I don't have an answer. I would be happy to know an answer if anyone in the audience have an answer about it. Instead, about making this as an exercise that can be communicate to people and to policymakers, they can understand exactly what's going on. So first of all, I think the descriptive part of this exercise is interesting in the sense that to find groups where there is different return to effort, different expected effort, no matter what is your expected outcome, no matter what is your effort. That's an interesting part. So I'm happy with the with the use of this description of the sample. What I I'm more and more skeptical about is the use of these references. So for me, the use of reference effort is okay because it has a meaning. No? So you know that you shouldn't smoke. So for me, if you smoke, I'm not going to compensate because you get you get lung cancer with a higher probability than someone from a richer family. I don't care. You shouldn't smoke. That's all. So I can see how a policymaker can say there is a reference effort. You know you should eat fruit. You know you should eat vegetable, etc. That can make sense. And also the reference effort turned out to be not so important in the measurement of unfair inequality. My problem is with the reference types, because the slope of the reference types decide whether 100%, if it is 0, or close to 0% of the variability you explained is going to be unfair. So you can say, okay, let's take so one option was when we were discussing this with Jones, Apostolos and Giovanna, one option was let's use as a reference the worst of type, the one with the lowest expected outcome. The problem is that the worst of type is like 3% of the entire population. Do you want to take the slope of a tiny group and say, okay, this is the reference for everybody? Not sure. So for the compensation consistent measure of unfair inequality, I would definitely say that you should take a weighted average of the slopes and use it, which is extremely close to use the ex post measure, no? which say, okay, it's not exactly the same because you take the average of the slopes and not the average of the realization, but it's very close in practical terms. So to get to Stephen's question, so I was really exhausted in explaining because the principal component is used to summarize behaviors. The scores, the 12 SF score is a rather standard health measure. In a previous version of the paper, we used this innovative measure of health, which is obtained like by taking a blood sample from a subsample of the UK panel. But the problem is that we were able to use this objective measure of health so basically this objective measure of health that we wanted to use were basically observed at the same time as behaviors, and we didn't want to have contemporary behaviors and health status because there is a clear reversal causality, no? In which you don't smoke because you had a problem, you had an heart stroke, you stop smoking, but that's not how you used to behave. So it's like we wanted to have some distance between behaviors and the health status, and that was the reason why we prefer this SF12 score, which is, to what I understand, rather standard way of aggregating health information. It would be nice to test this type of model with life expectancy, for example, which would be a much more objective measure of your health.
Okay, so we have 4 minutes left. So let me try and get everyone, Paul, Magdisi, Paul, Hufe, and Berkay. But if you could be brief with your questions, that would be great. So Paolo can try and answer them. So Paul Magdisi first, please.
A very simple question, maybe due to my ignorance. So you say that the SF12 is age adjusted, if I'm not wrong, age adjusted measure of health. Then you adjust for age, but then you also consider differences between gender. But then should we think about a gender adjustment? Like you were talking at the end about health expectancy. So if a woman dies exactly at the same age than a man, then this woman is probably deprived relatively to this man, because we know that there are some natural gender differences in life expectancy, for example. So is it possible to do that? That's my question.
Yes, that was what
Andrew... Sorry, Paolo. Let's get all the questions if you don't mind. Sorry, Paul Hufen.
I just want to ask, in the last part of the talk and also in the discussion, there was a lot of chat about the policy relevance of what you found. And I just want to play devil's advocate and ask, like, to what extent is what you have shown us today really more than just a nice academic finger exercise, in the sense that we only explain 8% of health outcomes, and now we come with this very elaborate normative machinery, different reference points, circumstances, efforts, and classify those things. But in the end, we still don't know anything about the determinants of health. So should we really take the little we know and those classifications now to make policy, or to give policy advice based on that?
Very good one. Berkay?
Thank you. My question is similar to Paul's, but like about the gender dimension and then like stock variables. But I can add to the last question saying that, can you think about this health as a stock measure? Entire same methodology could be applied. Let's say the outcome wasn't health, but then let's say wealth as a point in time accumulated to cumulative stock measure. Could you just do the same exercise with there? So is there something specific to the health that we see in these estimations?
Thanks, Paolo, please.
About Paul's question, of course, and this was one option. So, in fact, Andrew Jones and Apostolos wanted to have also a gender adjustment, but then we convinced them to have at least this version without. Policy relevance, that's funny. So we were asked by LSE to produce a policy brief from this paper, and we said no. We don't think that we can produce any policy brief from this, and that's because we share your skepticism, and we think this is an interesting attempt to test a theoretical model and a methodological approach to data. And unfortunately, the conclusion is that there is little we can do with these interesting machineries. Finally, Berkay, of course, I would love to, and I think it's extremely interesting, and maybe we will explain more than 8%.
Okay, well, that brings us exactly to 1:30. So thanks, many thanks to Paolo for a presentation. There was a lot of tough material there. I think he did a great job in explaining. So thanks a lot to Paolo, and thank you all for coming. And hope to see you next week for the effect of COVID on global inequality and poverty. So thanks again, and thanks to Paolo, and see you soon. Bye-bye.